Hi, my name is Kieran and I'd like to thank you for joining me today. And I'd like to thank the organizing committee for inviting me to give you this talk on understanding chronic pain. So for this brief talk, I'm not going to provide any data on, the burden of pain or the underlying pain physiology, or even the guidelines on management of pain, because there's general agreement, that pain is a big deal, that we understand, I suppose, the physiology of pain a good bit better now, and that whether we're talking about shoulder pain, back pain, or knee pain, there is a reasonable level of consistency on what we should be doing when managing persistent pain. So for today, I'm going to focus on how can we try to understand, first of all, what patients are experiencing by what they say and what they do, how pain and that experience impacts them, and how we can use that knowledge then in our assessment and treatment. But first, I suppose, and as an illustration of how badly I can get these things wrong, as well as writing papers and presenting at conferences, I write some pieces for mainstream media. And this is one example where we wrote a piece called 15 Things You Didn't Know About Back Pain for the main national newspaper in Ireland. It was, in a positive sense, very widely read, translated into multiple languages. And in that regard, you could say it had a lot of impact. I would say with reflection that the people who already agreed with me really liked it. But of course, they're not the actual audience. What you're really trying to do with mainstream media pieces is try and reach members of the public and people with pain to try and, I suppose, convince them about a contemporary view of pain. However, the feedback from the public was, let's say, mixed. So these are some of the quotes and some of the feedback we would have got on the comment section of the paper or another fora. And if you look through them, it's not exactly an overwhelmingly positive situation. And I raise this not to kind of say this is a bad sign of members of the public, but to show, I guess, how we took what we think were evidence-based messages and tried to communicate it in a way that was not judgmental or dismissive, and yet we still ended up annoying people and making them feel like we were dismissing their pain. And that's definitely not what we want to do. So what can we say about what patients are experiencing? Well, first of all, to better understand, I suppose, what patients are going through, the big thing is the easy thing. To start by, once we listen to patients, they will tell us. But that depends on us, first of all, knowing what to listen for, and that the healthcare system in which we operate gives us time to listen to them. Now, there's a series of studies, we could get into looking at them, but there's been studies looking at, what patients think about what's going on, their beliefs, about pain, whether it's back pain or knee pain and all the rest of it. But this systematic review by Mike Hurley, a Cochrane review, summarizes the situation for lower limb arthritis pretty well. It said that people are confused about the cause of their pain, bewildered by its variability and randomness, and they don't know what they should or shouldn't do, and as a consequence, avoid activity. So in other words, a lot of people with pain are confused, they're worried, there's a sense of loss of, their own self, and they have strong tissue damage beliefs. Now, that's what they say. What about what they do or what kind of care they seek? Now, again, this is partly influenced by, treatments that a person will choose, but also the constraints of the system they are living in. And that will vary, obviously, with, public and private systems and between countries. But again, if we look at the kind of studies that have been done on this, there is some consistent information. So, for example, on back pain, an Australian study, a systematic review done by researchers in Australia showed people with back pain, for example, what clear, consistent, personalized information. And then there's been lots of other studies, including by Haxby, who's chairing the panel this morning, looking at preferences amongst a group of people for the management of, for example, arthritis, and other people looking at back pain. And again, there's a lot of consistent messages. And some of this is easy because it's very hard to argue with giving people clear, consistent information. I can't understand why anybody would disagree with that idea, but what kind of information is that we should be giving consistently? And again, it's easy to agree when patients say things that we want to hear, like when they say self-management, it's great. We feel kind of reassured. But what if patients want what we might consider to be the wrong thing? So for example, patients also rate surgery quite highly. especially if it's persistent and severe pain, even if the guidelines don't necessarily say that's a good choice. And then there are different, I suppose, factors to consider when we're thinking about, what the treatments people want and choose. Are we talking about the most effective or the one with the best evidence? The one with the least harm medically? The lowest costs? How big a burden and how long is the treatment? How quickly does it work? And essentially it looks like that might differ between patient preferences, different patient presentations, but also depending on the healthcare system you're working in, your own individual socioeconomic status, or even like the wealth and resources of your country might also influence, the care that's offered. And then when we look at the impact of pain on the person, there are some common themes we see. Clearly, there's an avoidance of activities. But when we think about avoidance because of the concern about damage, or also just that it's a dangerous thing to do, this is probably a sensible choice of patients based on the knowledge and beliefs that they have. Like if I truly felt my knee was sore running because I was damaging my joint and wearing away the cartilage, I don't think I would run. There's also a great sense of frustration at the loss of, the ability to do the things they love, and maybe a frustration at, the stigma that can go with being somebody with persistent pain. And then, of course, pain is associated with multiple health complaints. So from mental health and a whole range of cardiovascular and even mortality complaints, even though these are strongly comorbid complaints. Equally, some of our well-intended recommendations around like trying to avoid harms through unnecessary imaging and strong medications, that can be a source of frustration for patients because it might be seen as being just a cost-cutting maneuver by the health service. On a slightly more positive note, there is some evidence that over recent decades, the balance between rest and exercise is probably progressing, and that now people are less likely to be told to rest if they have persistent pain and more likely to remain active. So that's good, it's encouraging. But even at that, we see there are huge terms and conditions applied when people are told to be active. So it's, well, you can be exercising, but you must be careful. You must go very gently. You can maybe do this exercise, but not that type of exercise, and only do it within these constraints, like on this surface with this type of footwear, only for this amount of time. So there's still a great sense of restriction. And I guess where I want to go with that, if we think about, well, what, I suppose, understanding pain in terms of, the patient experience and I suppose the impact on them, what I want us to focus on, I suppose now, and to be a little bit provocative, is how do we use this kind of knowledge to try and shape the future in terms of assessment, training of healthcare professionals, treatments, and so on. And so I've looked at a couple of different groups and I suppose what we possibly should be doing. So for example, if we look at it across the spectrum of clinicians, there's clearly a lot of outdated beliefs still there across, nursing, medicine, physiotherapy, and so on. And it's possible to change beliefs, even if it's tricky. But then even if we change beliefs, that's probably not enough because it's relatively easy to change beliefs about pain. It's much harder to change practice. So we've got to probably ask people a little bit more and listen a bit more in terms of especially looking at measures of distress and impact. We probably need to back off in terms of telling people so much stuff and going too heavy on the education. And I would argue that it's probably as important to consider permission about, getting back into activity rather than prescribing. So there's a focus sometimes on exercise prescription, but actually just helping people and giving them permission to get back living is probably as important. In terms of, depending on your country, whether it's the government or insurers, they probably need to allow us as clinicians to be generous with our time, but they can probably be harsh with the treatments we are offering or the treatments that are funded, and indeed conflicts of interest. Health systems probably need to have less silos where, the care of an individual person is divided up across different settings. And we probably need greater integrated community programs. There's also probably a need to balance having flexible choices available for people, but making sure each one of those is, evidence-based. And as much as possible, I think they should stop penalizing recovery. By that, I mean like penalizing people who have been involved in disability or on sick leave and penalizing them for recovery. I've also noted here a range of things that I suppose we should probably target in terms of the patients, professional organizations, universities, and indeed research funding bodies. And I'm going to leave those there because they might be things that we can come back to in a discussion. In conclusion, I think we have a much better appreciation of what pain does and doesn't indicate and the limitations of all current treatment approaches. Now it's probably important that we just start to consider the impact of our words and our advice on how that has limited, unfortunately, people's ability to live normally. I think we need to strongly yet compassionately restrict access to unhelpful treatments, however we define those. And as much as possible, if we're getting less of some treatments, provide more support for healthy living. And that's, pain, but general health also. And then in terms of training, current clinicians and future clinicians, we need to train people and reward people to provide supports that are the most important or that are currently unavailable. I'd like to thank you for your time.